Hello everyone. Today we will discuss about rickets. So first, starting with the definition. It is a disease of growing bone. It is a disease of growing bone. It occurs due to the defective mineralization of the cartilage at the growth plate. It occurs due to the defective mineralization of cartilages at the growth plate. This occurs before the fusion of epiphysis. It occurs before the fusion of epiphysis. Okay, so this is the definition of rickets. So it is a disease of growing bone. It occurs due to the defective mineralization of the cartilage at the growth plate, and it occurs before the fusion of the epiphysis. Next we will see the pathophysiology of this. So normally the bone consists of the protein matrix called as osteoid. So the bone consists of protein matrix. This is called as osteoid. This osteoid, that is a protein matrix, is laid down by the osteoblast. So this osteoblast cells lay down the osteoid. So once this osteoid is formed, it is being mineralized with the calcium. So this osteoid is mineralized with calcium. This is the normal process. When there is a defective mineralization, as in the rickets, so when there is a defective mineralization, this osteoid continues to get accumulated or continues to get deposited in the bone tissue below the epiphysis. So due to the defective mineralization, this osteoid gets accumulated in the bone tissue below the epiphysis. This leads to the expansion of the epiphysis at the growth plates, leading to the expansion of the epiphysis, which we see it as wrist widening. So once only this osteoid getting accumulated and there is no mineralization, it leads to the softening of bones. So once the bones are soft, it leads to increase in the fractures and bony deformities. Okay, this is the pathophysiology behind the rickets. Next we will see the staging of rickets. So staging of rickets. So there are 3 stages. So stage 1, here when there is a vitamin D deficiency in a child with vitamin D deficiency, there will be a intestinal absorption of calcium will be low. This is leading to the hypocalcemia. So there will be the intestinal absorption of calcium is low. After the staging of rickets, I will go into the vitamin D metabolism and their mechanism of action. Okay. So intestinal absorption of calcium will be low. This is leading to hypocalcemia. In this stage, the child can be can be silent, that is without any symptoms, or the child can have seizures also. Once there is hypocalcemia, it leads to secondary hyperparathyroidism. This secondary hyperparathyroidism, it causes bone resorption. It causes bone resorption. It upregulates the 1-alpha hydroxylase. So it upregulates 1-alpha hydroxylase, which leads to increased intestinal absorption of calcium. In renal, it causes increased calcium resorption. Second, increased phosphorus elimination or excretion. Okay, this is the stage 1 when there is a vitamin D deficiency in a child, starting stage. The next is stage 2. In this stage, the child's calcium level will be normal. This parathyroid hormone, alkaline phosphatase will be elevated. Since the phosphorus is getting excreted by the kidney due to this hyperparathyroidism, there will be reduction in the phosphorus, and the child will be having a physical manifestations of rickets, both clinically and radiographically. So there will be physical manifestations of rickets in the child, both clinically and radiographically. Okay, this is the stage 2. In stage 3, with the worsening of vitamin D deficiency, so when there is a worsening of vitamin D deficiency, the 25-hydroxycalciferol will also be low. It will fall lower than calcitrol, that is 1,25 dihydroxy vitamin D. Okay, so this will be lower than this, plus calcium will be low in this, while in stage 2 calcium will be normal. Because of the secondary hyperparathyroidism, the calcium will maintain its level, while in stage 3 the calcium will also be low and the parathyroid hormone will be elevated. So there will be florid clinical and radiographic features of rickets in stage 3. These are the staging of the rickets. I will next take the metabolism of vitamin D. Vitamin D metabolism. So it has a cutaneous synthesis and also by the dietary route. So in cutaneous synthesis, in our skin we have 7-dehydrocholesterol, which on exposure to the sunlight, that too mainly the UVB rays with a wavelength of about 290 to 310 nanometer, this 7-dehydrocholesterol is getting converted into pre-vitamin D, that is 3-cholecalciferol. This goes to the liver. There, with the help of 25-hydroxylase, it gets converted into 25 hydroxycalciferol. Okay. Next, this goes into the kidneys, which by the help of 1 alpha hydroxylase gets converted into 1,25 dihydroxycholecalciferol. It is called as calcitriol. This is the active form. Okay. In this active form, in the bone, it causes mineralization. In renal, it causes reabsorption of calcium. In intestine, it causes increased absorption of calcium. Okay. So when this 1,25 dihydroxy calciferol is increased, or when it is excess in quantity, this 25 hydroxy calciferol will get converted into 24,25 dihydroxy calciferol, which is an inactive form. This is an inactive form. Okay. So this is the metabolism of the vitamin D in a simpler way. Here in kidney, this 1, alpha hydroxylase is, this activity will be increased or get stimulated when there is increase in parathyroid hormone or when there is low phosphorus level, or it can be inhibited with increase in FGF23, that is fibroblast growth factor 23. When it gets increased, this 1 alpha hydroxylase will get inhibited, so 1,25 dihydroxycalciferol will not be formed. So this is about the simple metabolism of vitamin D. Next we will see the types of rickets. So in types of rickets, we have classified into two types. One is nutritional rickets. Second one is refractory rickets. In nutritional rickets, it occurs due to the deficiency of vitamin D, calcium, or it can be due to phosphorus deficiency. Okay, in nutrition rickets. While in refractory rickets, it can be vitamin D dependent rickets type 1 or type 2, or it can be hypophosphatemic rickets. In hypophosphatemic rickets, we have three types. One, it can be X-linked or autosomal dominant or autosomal recessive. Third, it can be due to chronic kidney disease. Fourth, it can be due to renal tubular acidosis, or it can be due to tumor induced rickets, or when there is a disorder secondary to increase in fibroblast growth factor, when there is a disorders which leads secondary to increase in FGF23. Okay, these are the types of rickets. First we'll go into the vitamin D deficiency rickets. So in vitamin D deficiency rickets, what are the causes? First one, there can be a decreased intake of vitamin D. Second, it can be due to malabsorption. So the causes of malabsorption can be celiac disease in a child, or when the child has a pancreatic insufficiency, or when there is a chronic cholestasis. Okay, these are the causes of malabsorption that leading to the vitamin D deficiency. Third, when there is a increased degradation. So when there is increased degradation of 25-hydroxycalciferol, it can be when the child has a chronic liver disease or some genetic factors. Next, when there is a disorders of vitamin D synthesis like dark skin pigment, or when they apply the sunscreen of increased SPF value, or when they are fully covered, this can also be a reason of vitamin D deficiency. Another one is when there is a decreased maternal vitamin D stores. When there is a decreased maternal vitamin D stores and the child is exclusively breastfed. This also can cause vitamin D deficiency. Okay, these are the nutritional causes of vitamin D deficiency. Next, calcium deficiency. So same as vitamin D deficiency, calcium deficiency, it can be due to low intake. Second, it can be a premature infant. Or when there is a malabsorption, or when your diet consists of inhibitors of calcium absorption. When there are dietary inhibitors of calcium absorption. These are the causes of calcium deficiency. Okay. And in phosphorus deficiency, same as this calcium one, it can be due to low intake. 2, it can be due to prematurity. Third one, when it is taken with the antacids, because all the antacid containing can inhibit this phosphorus. Okay, these are the causes of nutritional deficiency, rickets. Next, we'll go into the clinical manifestations. So in clinical manifestations, generally, the general manifestations are the child will be stunted growth. 1, it can be failure to thrive. Second, the child will be listless. Third, the child will have a large protruded abdomen. Fourth, the child will have a muscle weakness. The mainly proximal muscle weakness can be present. There can be increased risk of fractures or multiple fractures even with the minimal trauma. Next, in head, the child will be having a frontal bossing, this one, large forehead. The child will have a frontal bossing. A child will have craniotapes. This craniotapes is not a definitive feature of this rickets. This craniotapes can also be present in other diseases like osteogenesis imperfecta, congenital syphilis, and in hydrocephalus. This craniotypes can be detected by applying pressure at the occiput or over the parietal region. So the child will have frontal bossing, craniotypes. There can be delayed closure of the fontanelles. Delayed dentition. And then the child can also have craniosynostosis. Okay, these are the features of the child with the rickets in the head region, pertaining to head region. In the chest region, the child can have this beading in the ribs. Okay, so this beading in the rib bones is called rachitic rosary. That is beading of costochondral junction. Second, the child can have Harrison groove or Harrison sulcus. This Harrison sulcus is nothing but the horizontal depression of the lower anterior chest that is occurs due to the pulling of the softened ribs by the diaphragm. It is a horizontal depression of the lower anterior chest wall. This occurs due to the pulling of the softened ribs by the diaphragm. It occurs due to the pulling of softened ribs by the diaphragm. Okay, the child can get recurrent respiratory tract infection. This occurs due to the softening of ribs and impaired air movement. Okay. Next, in the back spinal region, the child can have scoliosis, kyphosis, or lordosis. In the extremities, as we all know, the child can have this widening of the wrist. In the extremities, the child can have one genu varum. This is genu varum, or it is called as bolex. Genu varum, or the child can have genu valgum, that is knock knees. Or the child can have double malleoli. The double malleoli, in another name, it is Marfan's sign, not Marfan syndrome. It is called as Marfan's sign. Okay. Another features are the child can have windswept deformity. So what is this windswept deformity? I'll draw it here. That is, one knee will be genu varum or genu valgum, another will be a knock knees. So this is called as windswept deformity. Okay. The child can also have coxa vara. So these are the features of general clinical features of the child with rickets. Next we will see the X-ray findings of the child with the rickets. One is widening of the epiphyseal plate. First change due to the loss of the first change that occurs, that is the radiological changes. So the first change, it occurs due to the loss of normal zone of calcification at the metaphysis. It occurs due to loss of normal zone of calcification at metaphysis This leads to blurring of the metaphyseal margin or irregularity, blurring or irregularity at the metaphyseal margin. This is called as, or this you interpret in the radiological image as fraying of metaphysis. This is called as fraying of metaphysis. Next, second. So as the cartilage hypertrophy occurs, it leads to widening of the growth plate. That leads to, this is called as playing or called as cupping. Because of the softening of the bones, because of the softening of the bones, there will be this cupping. Okay. Generally, there will be a decrease in the mineralization. So there is a generalized decrease in the mineralization that leads to the features of osteopenia in the radiological image. Okay, so what are these are the three important features. What can be the other features are: the osteopenia shaft of long bone and the thin cortices will be present. There will be a coarse trabeculation of diaphysis and generalized rarefaction that leads to ground glass appearance. Okay, so there's a coarse trabeculation of diaphysis. Fifth, when there is an extreme deficiency, it leads to pathological fractures. And the looser zone, it is called as milkman's fracture. Okay, so this is about the findings that you see in the X-ray of a child with the rickets. Okay, what are the serum findings the child can have if the child is having a vitamin deficiency with rickets? Lab findings: serum calcium will be normal or it can be low in severe vitamin D deficiency. One. Second, parathyroid hormone will be elevated. Third, alkaline phosphatase will also be elevated. And fourthly, you will be seeing 25-hydroxy vitamin D, which will be low. When it is less than 12 nanogram per ml, it is called as deficiency. When it is between 12 to 20, it is called as insufficiency. When it is more than 20, it is sufficiency. Okay. In phosphorus will also be low in the child with this vitamin D deficiency, while in urine phosphorus will be high because there will be a renal excretion of this phosphorus due to a secondary hyperparathyroidism, while urine calcium will be decreased or low. So these are the lab finding of a child with vitamin D deficiency, rickets due to vitamin D deficiency. Next topic, I will cover the refractory rickets. We will see in a simpler form of refractory rickets. Thank you. Please like, share and comment my YouTube channel. Let's all learn pediatric together.